Bismillahirrahmanirrahim. Assalamu alaikum. I think this afternoon we'll briefly discuss about basically the technique of how to take a long case. This we'll discuss. First of all, I'll try and mention what really happens and what should be done. Now, for a long case, you are given 30 minutes for history and examination. Now, history and examination has to be complete. What is noticeable during the exam is the fact that the examinees or the candidates normally do not take history at all. And it's very visible when you are actually taking the examination. It does not appear to be very professional. So my advice is, please take history of each patient you see, whether in the ward or in outpatients. Over a period of time, you should be able to develop ways where in minimum time you get the maximum information from the patients. Somehow, history is not emphasized upon. I remember it's been in 1983, I passed my MRCPS. In fact, it was February 1983. And I can remember that history was part of a routine on our normal working days. It says my internet connection is unstable. I hope you can hear me all the time. So I think if you are used to taking history as a routine, it will never be a problem. In any case, then following history and examination, you appear so nervous and you are so tense that half the time you miss out something significant, or you emphasize on some irrelevant point and waste a lot of time talking about it. So you have to be time efficient. Time management is also very important. 3 minutes, you will have to talk to the two examiners. Now the examiners, each one has 10 minutes each, and in 10 minutes, he has a major duty to perform. That is, watch your clinical approach and skill, plus assess your clinical approach and skill and the management diagnostic approach and a little knowledge, up-to-date knowledge about that particular case. And sometime we may even ask you about the sources of that information, that is the relevant studies, which means within 10 minutes, I have to find out enough about you to be able to pass you through the exam or hold you back. So remember, time management is your responsibility. Simple logic is that on one question you will not pass. So you have to consume your time in such a manner that your answer is brief and to the point. Okay. Now, when you are presenting history, you almost take about 7 to 8 minutes. And the examiners have to keep cutting short. And when he keeps cut you short, then you get a little messed up and confused. And then your answers, and half the time you even forget what you were saying, because you are not taking history and examination routinely as a day-to-day. So please do it with all the patients wherever you are. And that is the only way to be efficient in history taking and its presentation. Anyway, when you start to present, what do you do? Now, I have put down a case of, how did we get there? Okay. Now, I'm going to present a case, and you can time me. In fact, you can time me now. I start now. It's a 63-year-old Mr. MJ presented with increasing shortness of breath over the past few months, and now he's barely able to walk to a 50-yard without stopping. There is some dry cough, worse at night. He's diabetic for over 8 years, smoker for many years, with episodes of bronchitis during winters. There is family history of diabetes, including father and an uncle. Father died suddenly following months of somewhat being breathless and easy fatigability. No previous hospital admission for this particular patient. On direct inquiry, he admitted to having some heaviness on chest on effort. His medication includes sitagliptin plus metformin, sulfonylurea, and atorvastatin 10 milligrams daily. Clinically, he appeared comfortable lying in the bed with head slightly elevated, pulse 88 per minute, blood pressure 145/92, respiratory rate nearly 30, JVP borderline maybe. There is short systolic burn at the apex, and mild wheezing and crepitation in the chest. There is no edema or enlarged liver or palpable liver. Now here what we have done is actually completed the presentation of history. Now, why does it appear that it's finished in 2 minutes or 3 minutes? Because you only present the relevant points without missing out any significant past history, family history, medication, and all that. But what happens, you spend too much time on his breathlessness, that when he does this, he does that, when he does this, it happens, when it happens. So try and be to the point. So this is how you can present the whole history. And if the examiner wants to know anything further, he can inquire. Okay. And in fact, it will be better if at the end of the day, end of the history, you can say, this is the brief summary of the history, although there are some other points which may not be so relevant. Or you don't even have to say that. Or you have to say, this is the summary of my patient and his examination. That is where you end up. So the time management is most important, okay, in taking history and examination as well as presentation. Now what? You have finished this. Now it's up to the examiner to ask you whatever he wants. So simple question will turn up. What is your provisional or working diagnosis? So so obviously anybody interested in participating is more than welcome. Anybody interested in participating? How many people are there anyway? There are only 6 participants. Okay, not bad, not bad. It seems that next week's examination is not being participated by many. So anyway, so anybody wants to get involved? No. So provisional diagnosis. Oh, where are we? I thought provisional diagnosis okay. So provisional diagnosis would be most likely congestive heart failure. But since there is a wheeze, there is a possibility that there is associated obstructive airways disease also. Of course, he's diabetic. So on that ground, how would you proceed for management? So management will start in the emergency ward, where these are the important things that you need to know as soon as possible. There is an ECG, saturation, or blood gases if that's available, then urea, creatinine, and electrolytes, X-ray chest if possible soon, otherwise troponin and BNPs. So this will give you a working diagnosis. And of course, once you send these investigations, once you have seen the ECG, you need to decide how soon, or is there a genuine emergency? Do you have to act immediately? Yes, go on. Can't hear you. Can you raise your hand first so that we can? Or maybe you can write a message, isn't it? Where are we? You can write a question if you have to. Okay. So is at the moment, is there anything you want to ask or inquire, or you want me to elaborate? Okay. So we go one by one, all these things. Okay. Uh, Troponins were negative. BNP, I can tell you it's over 5,000. And of course, ECG, but okay. ECG shows a rate of 108 per minute. The poor R wave progression with deep T inversion in chest leads. Creatinine 1.4, upper normal being 1.3, potassium 3.8. With this particular information, you can start acting. Now, the positive side is where the diagnostic side that helps is number one, there are ECG changes, and of course, saturation is reduced, and BNP is pretty high. So, you know what to do. You need to initiate loop diuretic, furosemide, in whatever dose according to clinical condition you think is feasible. You need to start that. Now, you need to give them oxygen also. Don't need to give very high level of oxygen, but of course, oxygen where saturation is maintained around 94, 95, that should be given. Okay. Now I have to cancel the chat box to move the slide. Your internet connection is unstable. That's not nice. Can you all hear me? Am I clear? There are no no's, so I would assume I'm audible. Hmm? Okay. I need to move the slide now. Okay, so I think we start with diuretic treatment. And if we assume this is pulmonary edema, or so what treatment we have to be used for acute pulmonary edema? Next slide. Yeah, okay. So we need to give them oxygen, put them on a monitor for cardiac rhythm, and of course, two emergency treatment for pulmonary edema includes furosemide IV and and of course IV nitrates. Among nitrates, the best nitrate is nitroglycerin, but of course we also use a lot of dinitrates, so they're both pretty good. But the quickest acting and the shortest half-life one is nitroglycerin. So we use that. Along with that, it's preferable to use molecular weight heparin or heparin because these patients who possibly have not been very active, may have been bedridden and will be bedridden, they are at high risk of DVT and pulmonary embolism. And of course, aspirin, because we have already seen ECG changes which might well be related to coronary artery disease. So this is what one can start with. So what next now after this? Is there something we need to do immediately, or we wait until they improve and then we do the follow-up? Most of the time in emergency, okay, in emergency, you stabilize the patient with basic medication rather than overloading him with too many medications. Particularly oral medications should be as little as positive as possible in any emergency situation. Okay. Now, echo, I'm sure everybody wants to know about the echo or do the echo. Is the echo needed now or following formal hospitalization? This is basically based on hospital policies. But if you can have a quick look at echo, it will be helpful in emergency. But then if the diagnosis is pretty clear, then you may actually leave it for a proper departmental echo later on. In this case, the diagnosis is pretty clear. So most likely we can do an echo once the patient is formally hospitalized. Okay, there is a bit about echo, not detailed, but EF around 30 with apex and anterior wall being hypokinetic. Okay, in 2 hours time, patient has improved. His pulse is now down to 88, blood pressure 110/70. Chest is now much clearer. I don't know if I mentioned the chest finding or I missed it out. Uh, yeah, there was mild piece. Didn't miss out much. Okay, so chest is now clear. Now what next? The question comes that of course he continues with diuretics as needed. Now, what about adding other medications for heart failure itself? So when we are adding beta blocker in this particular case, are we going to have any specific selection or just any beta blocker will do? Of course, the beta blocker which has a little edge on such patients is carvedilol. And don't forget it's alpha and beta blocker, and it's a non-selective beta blocker. So in this particular patient is heavy smoker and of course already has some signs and obstructive airways disease. So I personally would prefer a cardioselective beta blocker. And you know there are more than one cardioselective beta blocker, so you can go by your own choice. Which beta blocker you like. Of course, dosage has to be adjusted, and with beta blocker, the old phrase still holds true: start low, go slow. Okay, so you can start, since his blood pressure is also normal, so you can start with low doses and slowly build it up over a period of time to the guideline directed medical treatment targets. So guidelines should always be kept in mind, and the target should be as per guidelines. So you start with a low dose wherever you feel comfortable and build it up slowly over a period of time. Now, what next? When to add an ACE inhibitor? Is there any question about adding ACE inhibitor? Or you think it's mandatory to start ACE inhibitor in all patients with whatever information we have on this patient? He with echo, ECG, everything. There is suggestion that this is secondary to coronary artery disease. So, so basically, ACE inhibitors has to be added now. And since there is no known contraindication so far, so ACE inhibitor has to be started. And again, any ACE inhibitor, but preferably those which have been studied upon. As per the earliest, the first I ever saw is enalapril, and then there is remipase, which has been studied well. So anyone that has been studied well, or any other, because now we know it's a class effect rather than a specific ACE inhibitor effect. So ACE inhibitor has to be started. Again, the dosage has to be started as per the patient's pressure and condition. And you can start on a low dose and then build it up over a period of time to the guideline directed medical therapy target dose. So target dosage should always be in your mind, and you don't have to rush into it. Over a period of time it can be done. So ACE inhibitor, generally there was a long time ago, people wanted to see if this work in acute situations. So there was a study done on acute pulmonary edema and acute heart failure, and this did not show any benefit. So this can be added a day later or 2 days later or 3 days later once the patient is relatively dry. Same as with beta blocker, the patient should be dried out, he should be relatively dry before you actually start the treatment. So Emergency treatment is basically diuresis, IV nitrates, and with or without heparins. So these medication comes later on, a day later maybe, but of course, if the patient is hypertensive in acute stage, then you can start ACE inhibitor for hypertension also, because they need to bring the blood pressure down also to help his heart failure and pulmonary edema. But in this particular patient, since there is no question about hypertension, the patient is blood pressure is okay. So this you can start a day or two later. Okay. When to add an MRA, that is eplerenone or aldactone. This you can start because this has diuretic action also. You can start along with if the patient's condition is good enough to take oral medication, then you can start there. As soon as possible, you need to add this medication. Now, these three medications, so far I've mentioned that beta blocker, ACE inhibitor, and MRA, they have survival benefit, rehospitalization benefit. So these are not benefits of these patients where in heart failure, as you know, mortality is very, very high. Somebody who has got pulmonary edema with severe LV dysfunction, the average survival or 50% survival is over a period of 2 to 3 years is not so good. Okay, next please. Okay, now at this stage, since the patient is stable in 2-3 days, is there a need for further evaluation during this hospitalization? Because heart failure itself is not a disease, it's a reflection of a disease. So we have to find a cause for heart failure. In this case, we have got indicators that this is probably related to coronary artery disease. Now, do we need any further evaluation during this hospitalization? That is the question you need to decide. Possible further evaluation that needs to be done in this patient? Okay. If troponin is elevated, then of course this is N-STEMI and they need catheterization during this hospitalization or soon after. There is no need for primary angioplasty in this case because this is not a STEMI. Okay? So you may decide on to do a coronary study with or without intervention as per the findings if the troponin is elevated. Now, if troponin is normal, then what next? Okay, we'll come to that later. Or let me just mention it. If the patient is stable, then there are two things you can do. Either you can go for a stress echo or dobutamine echo or a perfusion scan to evaluate further, or you can do a direct angiogram because LV is already down and you cannot afford to allow any further damage, even 5 to 7% damage to the myocardium can be. So I think it's up to individual physicians. Okay. Now, discharge medicines for heart failure. Of course, there will be other for diabetes and whatnot. I'm concentrating on this particular patient's heart failure. So diuretics as required, aldactone or eplerenone, that is MRA. ACE inhibitor, again, the dosage has to be adjusted as per requirement. Beta blockers, again, need to start preferably in this particular patient, preferably cardioselective. And of course, aspirin, because there is suggestion of coronary artery disease or ischemic heart disease. And statin, in any case, is mandatory. Number one, being a diabetic, he needs a statin. Number two, and more importantly, since there is evidence or suggestions of coronary artery disease, that means statin. So what is statin? Is it high intensity or moderate intensity statin? Obviously, it has to be high intensity statin. Of course, later on, in a month's time, 2 months, 3 months' time, when you recheck his lipids, and then you can come down to whatever you target. I personally bring the LDL down to 50 these days. And if it goes down below 50, then I certainly reduce the dose to keep it around 50. The days of 70 for the past few years, I have actually crossed that to and targeted to down to 50. These are again heart failure drugs, more recent, relative. One of them, Arni, is relatively recent, and dapagliflozin. And of course, now in the last, of course, within last few days, we have learned that empagliflozin is equally good. So Arni is now has now proved to be better than ACE inhibitors. It has 20% additional benefit in survival benefit and hospitalization. So what do we do? As per the guidelines today, Arni can be added once the patient has been discharged, 4 weeks, 6 weeks, whatever, and Arni can replace ACE inhibitor. There is a study only few days ago that came out, or not few days, few weeks actually, which suggested that Arni can be initiated during the initial hospitalization phase also. It has some benefit. But then it has to be reviewed, and it is, as per guideline, it is 1B, not 1A as yet. And of course, it is preferred because the higher benefit, you can add it in about 6 to 8 weeks time, or maybe 4 weeks time. But we'll have to wait if it is approved for initial starting this medication during the initial hospitalization. Dapagliflozin is actually a diabetic drug, which we have learned that it has high benefit. We will not go into detail of how it works, and nobody really knows how it works. It actually excretes sugar, and it has some diuretic action. So there is a theory that it may be diuresis which is affecting, but diuresis alone does not give you mortality benefit, which it does. So we still have to wait and see to find out its mode of action, but it has been approved for use in heart failure, even in non-diabetics. So these two drugs can be added at a later stage, one replacing the ACE inhibitor and two as an adjuvant. All this actually raises a question about the cost of management and of course polypharmacy. But then until we learn more, I think we'll have to do with that. Now, I think my final slide coming are going to be the 4 pillars of treatment: beta blockers, MRA, ARNI, and DEPA. ARNI comes before DEPA, but over a period of time we'll learn which is more significant and more important. These are the 4 drugs which provides you with actually mortality and rehospitalization benefit, and of course quality of life. So diuretics are for symptomatic benefit. They do not provide us survival benefit, but of course these are the 4 drugs which will be the pillar, or are already the pillar of heart failure treatment. So all patients, whenever possible, they should be on these 4 drugs if they have heart failure, chronic heart failure particularly. In acute heart failure, it may be flash pulmonary edema, which may recover and the cause may be removed. But of course, now, when it comes to heart failure, there is heart failure with reduced ejection fraction. Up to now, I've been talking about everything in context of present patient and his lives. That is heart failure with reduced ejection fraction, that is HFrEF. Of course, HFpEF, that is with preserved ejection fraction, we still don't know if any drug is providing mortality benefit or re-hospitalization benefit. In fact, only recently with ESC, Army has failed, whether it was related to the study design or whatever we learn in future, but up to now, for preserved ejection fraction or diastolic heart failure or HFpEF, we do not have any specific treatment. So it has to be treated as usual, that is diuretics and whatever for basically. So we are just discussing about uh, heart failure, HFpEF and HFrEF. Of course, mid-range is being discussed. That is between 40 and 55 ejection fraction. But I think when it comes out, when it becomes established, we can talk about it then. So in this particular patient, we have got clear-cut diagnosis of heart failure, secondary to coronary artery disease with reduced ejection fraction. He's diabetic. So diabetes needs to be managed as required. And of course, his discharge treatment, we have already mentioned with all these drugs. Uh, Discharge treatment, we've already talked about. Now, these four drugs, he should be on it in 4 to 6 weeks' time. So, as I mentioned, DEPA and ARNI so far are not recommended in the first hospitalization of heart failure. So, they go back home on ACE inhibitor and later on shifted to ARNI. And again, I would repeat, there is a study that came out suggesting that ARNI can actually be initiated during the hospitalization itself, but then it's still not part of the guidelines. So now I think we'll stop here. We have finished the whole thing in, I think, about 45 minutes. So this was all about how to get through the exams. So questions, answer. Whenever you are answering, be to the point. If you try and to be very broad, you are opening up Pandora's box. Now, if you get into trouble with the difficult question, it is not the examiner, it is you who has actually during your answer has mentioned something which you are not very sure about. So one tip I'll give you, whenever you are answering a question, emphasize on a point that you know very well. That means you are leading the examiner towards something that you know very well. Okay? That helps you. Now, this is basically exam, passing an exam is whether you win or the examiner win. Basically, examiner hardly ever tries to win, as one of my teachers actually told me, that all of us examiners, we come for the examination with the objective to pass you, not to fail you. You fail yourself. Sometime you may find that examiner have not been very just to you, but remember, somewhere you have caused a problem for yourself. Okay? It is your answer. And remember, when you are answering, always start off with something with the commonest, with the simplest and commonest. If you start with the rare thing, with me, you actually lose. Because rare thing you will probably hardly ever see. The tendency of our society that we believe that if you tell something that nobody else knows, you get a distinction. I'm sorry, no. Something that you will hardly ever see in your career. Why do I want to know about that? I want you, the target baseline is we have to assess how safe a doctor you are, or how safe a consultant you are, no more just a doctor, a consultant, a specialist. How safe are you? Patient safety is number one. That is why you need to start with basics. You cannot jump on a sophisticated treatment without dealing with the basics. Sorry about this. So these are the few tips and tricks for long cases. And if there are still any questions, I should be happy to answer. I've got 8 participants. I was expecting a few more, but then that's life. People must be very busy because as I miss out too many things because I'm too busy. Okay. So is there anything anybody want to add to what we have discussed already? Or maybe it's chat box is open or not. Can we give EMPA in heart failure without diabetes? Of course, I think dapagliflozin is already approved for heart failure without diabetes, and EMPA, I'm sure within weeks it will be approved because EMPEROR reduced trial that came out during ESC over the weekend shows even better benefit. It will not be out of place if you use it. Now, once again, I repeat, the study came out on DEPA. I have been insisting that it is a cardiac drug and less of a diabetic drug. So please use it even in non-diabetic because it does not reduce the sugar very much. Only mild reduction of sugar, that is over a period of 12 to 8 months or so. Excuse me. It reduces HbA1c by 0.9. So you can see it's a mild sugar reducing drug. There is one problem with this group of drug. There is increased incidence of UTI. So patients with recurrent UTI, you should be very cautious, and if occurs, then please don't use it. But specifically, it is a fungal infection worse, and that is more common with gliflozins. And that is where our limitation with this group of drug, that is empagliflozin, dapagliflozin. If you get recurrent infection, you may have to wait. If there is no other question, I think we can wind up. And all the best for all the candidates for the exams starting next week. Okay, nothing more on the chat box. All right. Okay, thank you very much, and Allah Hafiz.